Okay. So made a few Osce. So this is a, just a minute. 30 day, 30-day old preterm. It was 28 week, 5 days to start with, developed recurrent apnea and feed intolerance. Can we have answers in the chat box? Or somebody can unmute. And intramural gas. And where is the intramural gas? And anything else? Yeah. Yeah. Just near the duodenum, there is intramural gas, and it's a NEC. And what stage of NEC? Can anybody write there? What are the likely finding in the blood reports? What blood reports will we order? Is there a triad? And what are the evidence-based intervention that can be used to prevent such condition? And in this stage, what will be the treatment? So thrombocytopenia, hyponatremia, metabolic acidosis. Yes. Yes, 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 yes. So what stage of NEC is that baby in? How do you classify the stages? Stage 2B, stage 2A. Yeah. NBO, antibiotic, serial monitoring. Yes. So it is stage 2B. What are the likely blood reports? Metabolic acidosis, hyponatremia, and thrombocytopenia. 3 evidence-based intervention: antenatal steroid, human milk, and probiotics. Do really probiotic helps or no? There is conditional recommendation from NNF and Espagan that probiotic may be used in preterm child, and it decreases the incidence of late onset sepsis and NEC. This stage 2B will keep the baby NPO, antibiotic, surgical intervention if there is, worsening. Not right now. Not right now. So this is a table from Avery, and which says suspected, definite, and advanced 3, and there are systemic signs, intestinal signs, and radiological signs, and that corresponding treatment. So our child is in stage 2B, so there is medical management, not surgical management. Had it been, a peritonitis, then we would definitely go on for surgical management. Next is, can anybody identify this picture? So what's the diagram? What's the size of circle shows, and what's the size of the weight of the line shows? Very good. Ramya Rajkumar, network meta-analysis. What does this circle shows? Yeah. I've lost this.
So you may go to the previous slide also, so that everyone can see the image.
I have lost your screen sharing.
Yeah, we can see the ASCII 2 screen, sir. Questions.
You can see my screen, but I cannot see.
Okay.
Nice. Is that?
You may reshare, sir.
I may?
You may
reshare.
reshare. Yes, yes. You can share it again. Yeah.
Yeah. So these are network analysis. And in this, there are two things. See, so one is this large circles, and these are lines. So these are,
we cannot see that slide. That
you
slide
cannot see the slides.
We can see the slide, but the network meta-analysis slide is not there on the screen. So you may start the presentation mode, sir.
Presentation mode.
Yes. Now it is there.
Not there?
Yeah, it's there, sir. Okay.
So these circle, and these are the large lines. So circle says the how much sample size was there. The larger the sample size, the bigger will be the circle, and how many direct comparison has been between the two arms of the experiment. So the thicker is the line, that means the more studies have been done between these two things. So this is, I got it for bronchiolitis, and see the largest number of comparison has been made between salbutamol and epinephrine. So the line is thickest and the circle is the biggest. Circle big means that the largest sample size, and line means the largest number of studies between the two. This network analysis. So this makes life easier. Like how many? There are thousands of RCTs. So in that we can find out that this was the result. Now OSCE 3. So can anybody tell what the three waveforms are? First is volume waveform, then a PV loop, and a flow volume loop. And there's something in three waveform that the moving arrow shows. Can somebody tell me? Just a checkbox. Yes. See, there is a leaking everywhere. The volume, some volume is getting lost in each breath. So what does that means? That shows there is a leak. Now there is a flow volume loop, and there is an inspiration followed by a expiration. Now there is inspiration, and then in expiration, do you see such kind of figure? What does that mean? Anybody? Have been working in an ICU? Obstruction, secretion. Yes, not obstruction. Obstruction, there will be scooping, but this is secretion. All these hazy features, they are secretion. You do suction, or there can be water in the tubings. So sometimes when water in the tubings or secretion can cause auto triggering also. So you should be careful, and you should teach your nurses a basic of graphics. Mm. Is OSCE 4. There are two lines in this small baby. Okay, how do you identify this line A and line B? Line A and line B. A is a UVC, okay, and B is a UAC. How do you identify that? A then generally goes straight. B usually take a U-turn and then come up. So what are the ideal position of a UAC and UVC? The chat box. Somebody is writing crux of diaphragm for UVC. T6 to T9 for what? And third is accommodation indwelling time. So for ideal time, UVC is ideally, IVC to RA junction that correspond to around T8 to T9. Ideally, see, 90% of UVC cannot be placed at the right place. So ideally, we should have a real-time echo, a functional echo to find out it should be just before the entry to RA, at the junction of IVC to RA. And we can keep them ideally for less than 7 days. However, if incidence of sepsis in your unit is very low and it's very difficult to obtain a PICC line, or there's a need of prolonged parental nutrition and the baby is very small and sick, we can prolong it for 10 days maximum, not more than that. UAC should be like preferred T6 to T9, a little higher, and maximum of 3 to 5 days. Ideally, 3 days, not even 5 days. One more thing, that question I've not written here, can we feed the baby with a UAC in place? Can we start enteral nutrition with a UAC in place? Yes, 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 yes. Yes, we can feed the baby. In fact, if somebody is doing a functional echo, we should do a Doppler of SMA and celiac. If there are forward flow, we should feed. Okay. Next. So anybody has an idea what does this mean? What is this? Doppler at 32 week. What does stage A, B, C means? So there is a peak and a trough. The peak is a systolic waveform and a trough is a diastolic. So the flow during systole and a diastole. So who have answered? C is reversal, decrease diastole, FGR. We do in FGR, however, in this we cannot find FGR. This is umbilical arterial Doppler. So initially there are increased resistance, the systole diastole ratio increases, the flow in the systole remain high and the flow during diastole decreases. Then there is absent end diastolic flow. So B is depict absent end diastolic flow. C is a reverse end diastolic flow. So how it is useful for us? It is useful for predicting. The worse is the Doppler, the worse the outcome of baby is going to be. And with this we can decide when the baby is supposed to be delivered. So initially, we see, when do you deliver such babies? Absent and diastolic flow. 30 week, 32 week, 34 week, 36 week. Anybody? Or reverse? Or do we do anything else apart from that? So this is one of the way of monitoring, or the Doppler indices to monitor. There are multiple Doppler indices. After when there is increased SD ratio, then there's a MCA Doppler get abnormal, then there is a absent, then there is a reverse, then there is a ductus venous changes also. So prematurity itself is, we have to weigh both of the things. You cannot with the absent and diastolic flow deliver a baby at 26 week or 27 week, because the 24 week the mortality is 50%, 26 week the mortality is around 20-30%, but there's a lot of morbidity, the cost is also involved. So you have to balance out both all the things. And Barcelona protocol somebody has written, yes, definitely reverse repeat in 12 to 24, that's pretty early. Your bi-weekly you should do at least 32 reversal, 34 absent. Ductus venous changes. Yes, most of them have given good answers. So I made a small table here. Just show you. So we'll do a suspected IUGR. We'll do a weekly Doppler, and as a normal umbilical artery, we'll consider the delivery at 38, 39 week with IUGR also. If there is decreased diastolic flow, then deliver at 37 week. If there's absent, 34 week. If there is reverse, then 32. This is how it goes. There is a hypoxia, then there is a decreased fetal growth, then fetal polycythemia, then there is a flow redistribution, then there is a rising umbilical artery indices, that's SD ratio. After that, the MCA Doppler, then brain sparing comes, and after that, there is a amniotic fluid decrease, there is oligohydranose, followed by asphyxia changes, not asphyxia per se. In a preterm, asphyxia changes means umbilical artery absent and diastolic flow. There will be then loss of fetal movement. Then there will be FHR variability loss. Then there is a reverse end diastolic flow. Then there is a ductus venosus changes. Only if there are ductus venosus changes, we should deliver more less than 30 weeks. Otherwise, all before it after 30 weeks only. There is a very simple OSCE. Can anybody identify what this is? Simple but very important. So there is a shaker water bath, there is a hot air oven, there is a freezer, there is a yeah. So breast milk bank, human milk banking. Yes, it's a milk bank. Yes, milk bank. So what are the advantage of milk bank? Why should we have a milk bank? This is the most important thing to prevent NAC in your unit. When I was, doing my neonatology, we used to have hell lot of NAC. That NAC has really, really come down. I think so. It's less than 10% what we used to see, even less than 5% that what we, even in extreme preterm also. So donor human milk or exclusive human milk feeding is a very important. Drugs that are contraindicated in donations. For donation, yes, there are some permanent, there are like triple H, where HIV, hepatitis B, we should not donate. But say the certain drugs also we should not. Which drugs are not contraindicated? That is important. Insulin, SSRI, low dose OCPs, thyroid, asthma inhalers. We should not discourage them from donating. Alcohol is a strict no, and at least even for breastfeeding mother, they should not breastfeed the baby within 12 hours of taking alcohol. How do we pasteurize? That's a holder pasteurization. We keep the milk at a high temperature of 62 degrees for 30 minutes, and then followed by a rapid cool, and then we freeze it. So, some biotic proteins in breast milk, lactoferrin, lactalbumin, alpha antitrypsin, lipoprotein lipase, bisalt stimulated lipase, HMO. Can anybody tell me what is HMO? HMO is a human milk oligosaccharide. That's a probiotic. Probiotics mean those substances that give help in promotion of formation of this thing, probiotics. It's a the effect of pasteurization. Pasteurization decrease lot of good bioactive materials, bioactive component of breast milk. However, it is better than any formula or anything else. Phosphate 7 we all are using. Everybody is using or no? So what's the protein why do you use why do you have to supplement with HMF? Any advantage? Any short term, long term advantage? Every prevent EUGR, fortification, bone disease in preterm. So is it for calories or it is for proteins or it's for minerals or it is for everything else? See, there was a study by Aaron's class which classified babies who had EUGR, and those babies who were in the lowest quartile, they had a poor neurodevelopment outcome. However, a lot of studies need to be done. Yes, somebody has written Vinayana. So she has written rights neurodevelopment outcome in Indian settings where see it good feeding help in decreasing the incidence of BPD. So where we are not ventilating properly, sometimes most units do not have a volume guarantee mode. Some babies are still being ventilated without a flow sensor. So good nutrition is a thing that helps that compensate for that poor ventilatory strategies. Plus there are a lot of infection. So if you keep the nutrient component high or normal, and it has a lot of minerals that will prevent HMDs or metabolic bone diseases. Do we need to supplement iron or calcium with HMF if given adequately? How much vitamin D one sachet of Lactodex has? Do anybody have an idea? Vitamin D is almost 140 unit per sachet. So if you give 6 sachet in a day, that's more than sufficient to give vitamin D to the child. Iron, if you have to supplement with like 2 mg per kg per day, and if you're supplementing enough, more than 8 sachet are enough for a child to have enough iron. Okay. When do we start giving HMF? So there are a lot of recommendations. Now they have started 50 to 80 ml per kg per day. However, most unit use it at 120 ml per kg per day. So how to administer? It is 1 HMF per 25 ml of EBM. We should not over concentrate also. It increases osmolarity and might lead to NEC. However, in a standard setting where 1 HMF is given with 25 ml, there has like NEC has not been noticed any higher than without HMF. Okay. X-ray, a little bad X-ray. This is a 27-week male child at 1 hour of life. So image here a little distorted. It's been over, expanded. So anybody, 1 hour of life, 27-weeker with a very poor X-ray. It's a RDS. Can anybody grade RDS in this child? Grade 3 RDS. And why grade 3 RDS? Why grade 3 RDS? Aeromechanic grading is there. So where you can see retrocardiac air bronchogram is a grade 2 RDS, where the cardio, this thing, pulmonary angles are blunted, grade 4 RDS, and a complete white out is a grade 4 RDS. So somewhere around grade 3, grade 4 RDS. It's a severe form of RDS. So how do you grade RDS? Indication of CPAP in a preterm and when? So can anybody tell me that which preterm should we give put on CPAP? Like a 32 week, 34 week. Should all of them be put on a CPAP or what? Moderate RDS. It is RDS or it's clinical, is RDS a radiological disease or a clinical or both? And how do we treat it? Clinical, yes, yes. So if the baby has, how do you classify respiratory distress in a preterm child? Any score? SAS score of 3 or more, early CPAP in delivery room. So advantage of early CPAP is that is right. So early CPAP decreases need of mechanical ventilation, requirement of surfactant. Yes, 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 yes. BPD? Yes. Is there an advantage of NIPPV over CPAP in preterm child? In a preterm child, synchronized NIPVV decreases incidence of apnea and post-extubation failure, but non-synchronized NIPVV do not have any advantage. So if you're giving NIPPV, it should be synchronized. Non-synchronized do not have an advantage. Now, what's the indication of surfactant in a baby having RDS? Indication of surfactant in a baby having RDS. Do all babies require surfactant? PEEP of 6 or more, or FiO2 more than 30%. Yes. So PEEP of 6 or more and FiO2 of what are the indication of surfactant other than RDS? Meconium aspiration, pneumonia, PPHN. Yes, that's right. So we've already discussed most of them. Do you know what kind of surfactant are available? Do we know? Do we administer human? Animal derived or synthetic surfactant. So animal derived surfactant are to be used. Most of them are, they have different doses. Curosurf has an advantage if given at a higher, dose. 200 mg per kg has a higher survival advantage and at a lower volume. So Surventa to be given 4 ml per kg. Curosurf to 1.25 to 2.5 ml per kg. 2.5 ml has an advantage over Neosurf and Surventa. And it should be early prophylactic surfactant. It should not be late. So early prophylactic surfactant means surfactant to be given within 2 hours of age. So if there is a PEEP of 6 or more, a 5 to more than 30%, in setting where of prematurity, you should give surfactant So in a or any baby who has been ventilated because of respiratory distress should be given surfactant. So the best way of surfactant is giving by Lisa or a mist, but if not possible, ensure. But and there's no need of continuing mechanical ventilation after giving surfactant if baby is breathing spontaneously and pressure requirements are low. Okay. After 72 hours, usually surfactant is not to be given. A repeat dose of surfactant can be given if there is persistent FiO2 requirement of more than 30% in a small child. This is a 25-week male baby ventilator dependent on 20 days of life. So anybody can define BPD, a physiological new definition of BPD. Can we say BPD at 20 days of life? We can say evolving BPD, but not a BPD. BPD is like to be classified around 35, 36 weeks of post menstrual age. So it can be, we can say PI, pulmonary interstitial emphysema. Yes, a precursor of BPD. So what can be the preventive strategy antenatal, during delivery, during labor room, and after delivery? Do antenatal steroid have any benefit in BPD? Have you read any of them? So antenatal, if we can decrease incidence of sepsis in a child, then BPD will be less. BPD do not directly, in any of the study decreases the thing, steroid, antenatal steroid decrease BPD. However, in Indian settings, yes, it would decrease. It would decrease because we like we will since we are not doing a very synchronized and volume targeted ventilation. So in India, definitely steroid will decrease BPD, but not found in Western setup where the ventilation is quite good. However, during delivery room, non-invasive ventilation should be done. So one thing, FiO2, you should keep FiO2 to maintain a saturation of 91 to 94. High FiO2 can increase risk of BPD. Then caffeine, definitely. PDA management. However, I'm not saying you should treat all PDA. Symptomatic PDA, yes, are associated with BPDs. Poor nutrition is associated with BPD. Okay. So early treatment of HSPDA. Yes, if it is symptomatic PDA, definitely. So early CPAP TPs, asepsis, open lung ventilation, permissive hypercapnia, PS with volume targeted ventilation. That is the most important thing to be done. Volume targeted ventilation. And what should be the volume target? So in this child's 24 weeker, volume target will be 6 ml per kg, yeah, 5 to 6 ml per kg. So if there is established BPD, then what ventilator strategy will be, and how different it is from RDS. So we're starting from rates. So in a RDS we'll keep a higher rate. In BPD we will keep a lower rate around 35, 40. In RDS we will keep a volume to be 5, 6. Here also volume will be higher, but pressure requirement will be a little higher. In this TI and TE especially, TI is going to be long and T is going to be short. So in BPD, ventilator strategies are like this only. Okay, yeah, great. Why TE? Is BPD a airway disease or a parenchymal disease? It's a disease mostly of airways now, with some parenchyma. It's a heterogeneous disease, air trapping. Yes. So it's an airway disease. So we have to keep a longer TE. Now there are just brief potters. So just 4 X-rays that I've kept. So one is on the left hand side. What do you see? And on the right hand side, it is similar. See, the right side of the lung is hazy in both of them, and left is relatively, has a lot of, radiolucent. So collapse consolidation. Which side is collapse consolidation? They're two different, X-rays. They are not same. And you see in the one on the left-hand side, the mediastinum is shifted toward, and there's crowding of ribs. So this is collapse, the one on the left-hand side of your screen. And the other one, the mediastinum stays there, and there's no crowding of ribs there. So that's a pneumonia. That's a consolidation. How do you differentiate between right one is one lung ventilation. Right one is a one lung ventilation. Could be, but right one, it's a pneumonia. So you can see helium and there's no collapse. One lung ventilation will cause collapse. So this is a consolidation. Yes, the tube is a little in, it should have been pulled a little, but still not a one lung ventilation. You can see helium, no? Yeah. Next. Yeah. So the one on the left with the hazy left side, but the mediastinum is a little, you see the mediastinum is pushed towards right a little, and in fact there is distension of the ribs. There's no crowding of ribs. Pneumonia never pushed the mediastinum to the other side. Pneumothorax, which side? Pneumothorax easiest. Pneumo on the right. Yes, that's easiest to find out. Why? Mediastinum is shifted. Lungs, you can see the lung margin, and there is hyperlucent shadow here. Here, this is pleural effusion. The one on the left hand side, there's a pleural effusion. See, the space between the ribs has increased. The mediastinum is shifted towards the right. Okay. Thank you. Best of luck. Sir, I'm done. Dr. Dipin.
Yes, sir. Thank you so much, sir. It was a nice, OSCE, sir, very informative. And the case discussion also very informative, sir. Thank you, Dr. Hemant, sir, as well as Dr. Vinay, sir, for moderating 3 cases. We are now more than almost 10:30 we have crossed. And still very fortunate to have you all. Thank you, sir. Now we are closing the session.
Okay.
Thank you, sir.
Thank you,
Good
sir. Sarita madam, thank you. We are closing.
Thank you, sir. Good
Yeah.
night.
Okay. Thank you.